Ik hoop dat iedereen weer terug is. I hope everybody's back with a fresh cup of tea or, well, a glass of wine is fine too. Not for Laura Rosenberger. Laura is a surgeon at Duke Cancer Institute in the US. So it's more of tea time or coffee time for Laura than it's time for a glass of wine. We're very, very happy and proud that Laura has agreed to give a talk on Phyllodes tumors. I'm in close contact with Laura on this specific subject that's very close to my heart. And Laura has pre-recorded her video, so we will show the talk, but she's present live, and afterwards she will therefore be able to answer all your questions. So let's start the video.
Good afternoon to you all in the Netherlands. It really is my pleasure to join you today, and I'm really sorry we could not connect in person. I want to say thank you to the organizing committee, and I will have to come visit sometime in the spring perhaps. I have no financial disclosures. This is an overview of what we'll cover in the next 30 minutes, and I'll have some case examples on the right that you can see as we go along. Phyllodes tumors were first described in the 1800s, and while they were originally termed cystosarcoma phyllodes, that is a term that we no longer use. As you know, these are biphasic neoplasms, which means they have both a stromal and an epithelial component. They're similar to fibroadenoma, but with specific diagnostic histologic features. They're classified into 3 subgroups: benign, borderline, and malignant, and they make up about 1% of breast tumors here in the United States, but that alters in other countries. And in Singapore, these tumors make up 8% of their primary breast tumors. These present clinically like a fibroadenoma with an enlarging, painless, palpable mass, but have a more rapid growth and present usually with a larger size. They present in women a few decades later than a fibroadenoma with a median age of 40, and that's one way we can distinguish them in a preclinical setting, or can help. And although we have detected these in girls as young as 9, they classically present in the 40s. On imaging, these really are indistinguishable on mammogram or ultrasound from fibroadenoma, and unfortunately, even a core needle biopsy is often non-diagnostic due to histologic overlap between benign phyllodes and fibroadenoma, as well as intratumoral heterogeneity. When taking women to the operating room for an excisional biopsy who had a core needle biopsy of a fibroadenoma, the upgrade rate is just under 10%. That means 10% of women with a core biopsy of a fibroadenoma will have a phyllodes on their final surgical pathology. And this situation usually occurs if that initial breast mass is large at the time of detection or is enlarging over time, and we decide to take them to the operating room for an excision. The upgrade rate, however, for a fibroepithelial lesion going to the operating room is much higher, and that's at 30%. Fibroepithelial lesions are usually called this when they have some hypercellularity or stromal overgrowth or elevated mitoses above what we would expect. And this is slightly institutionally dependent from site to site here in the United States. So how do we manage these breast masses? So we use the American College of Radiology, or the ACR's BI-RAD system, to determine which masses need biopsied, how we follow these, and which we take to the operating room. So for a probable benign appearing solid mass, they need to be well circumscribed, oval in shape, parallel to the skin in orientation, so usually wider than they are tall, and pretty homogeneous. And you can see an example there of what is a pretty classic fibroadenoma versus something that ended up being a phyllodes tumor. Classically, patients will receive a baseline exam, and if the mass meets all the previous criteria, it's given a BI-RADS 3, probably benign, and then followed. And these are repeated ultrasounds at 6, 12, and 24 months. And then after 2 years of follow-up, if they are stable, they get reclassified as truly benign and need no further imaging. If at any time that mass is over 3 centimeters, including at the first detection, that usually prompts a core needle biopsy here at our institution and a discussion with a breast surgeon. Classically, we'll excise these breast masses if they're large right from the beginning, 3 to 4 centimeters or bigger. If they enlarge over that follow-up timeline, oftentimes if the patient is in the older age categories, certain features on that core needle biopsy, as we just discussed, and if a patient simply prefers. These masses really are indistinguishable by clinical exam, by imaging, and now also by even core needle biopsy. This slide is just to show that even on surgical excision, these tumors may look very similar to one another on gross exam. So you can see 2 phyllodes at the top of the screen, benign on the left and borderline on the right, while the bottom left image is a completely benign but very large, almost 10 centimeter tubular adenoma. And the bottom right is on the other end of the spectrum. This is a 10 plus centimeter primary breast sarcoma. This is the current classification system for phyllodes tumors, and the final designation of the benign, borderline, and malignant is really based on these 5 scaled histopathologic features. Those are the stromal cellularity, atypia, presence of stromal overgrowth, mitoses per 10 high-powered field, and the histologic tumor border. So just as a reminder, this is what the edge of the tumor looks like under the microscope and not the pathologic surgical tumor border or margin. The last feature is any malignant heterologous elements like liposarcoma, osteosarcoma, chondrosarcoma, those automatically get the classification of malignant even if the other categories are not met. It is notable that Phyllodes tumors classification is quite challenging for a number of reasons which are listed there on the left. The American College of Pathologists is an organization that standardizes cancer specimen reporting, and there is no current reporting template for phyllodes, even though that does exist for other rare tumors such as GIST. So for low volume centers or times when there's diagnostic uncertainty on the final excision, we do recommend here in the United States a pathology slide consult at high volume centers. And the 3 big ones here in the United States are Memorial Sloan Kettering, Dana-Farber, and the Mayo Clinic, based on a few national pathologists who are really interested in this tumor. Just in the last month, based on a multi-center study showing a lot of omission of these histologic features that are used to classify Phyllodes tumors, we just completed the writing of a Phyllodes tumor cancer protocol template, which is currently open for comment and hopefully will launch later this spring. This is the distribution of Phyllodes tumors, and this is based on a meta-analysis that was published a couple years ago. This is just part of the table, but what you can see is that benign make up about 65%, borderline 20%, and in this meta-analysis here on the left, malignant make up 16%. The 2 other largest series in the literature are from Pui Hoon Tan, which is out of Singapore, and those are the breakdown of benign, borderline, and malignant, and the multi-center study that we published here in the United States showing those numbers. In general, when I'm talking to patients, I quote to them 70% benign, 20% borderline, and 10% of these will be malignant. I have just a couple case examples here that we can walk through. This is a 22-year-old female. She presented with a palpable mass that she initially described as something the size of a grape. A couple months later, she reported it had grown to about the size of a walnut. She was a university student, and a couple months later, when she returned from college to her home, she had an ultrasound showing a 4.5 centimeter breast mass. Based on the size alone, she underwent a core needle biopsy, which was reported as a fibroadenoma, and ultimately we went to the operating room for an excisional biopsy. Excisional biopsy, of course, is an enucleation, meaning no attempt at a surgical margin, and this was decided because of her very young age for the very bland findings on her core needle biopsy, and despite the growth rate, she's unlikely to have a Phyllodes tumor. However, on final pathology, she did have a 4 centimeter benign phyllodes, And you can see the very classic architecture there on the top right image. Mild cellularity, mild atypia, no stromal overgrowth, very few mitoses, and a well-defined pushing tumor border. So because we enucleated, she had, of course, all positive margins. And after a discussion, we decided to go back for a margin re-excision. Notably, this was a couple years ago and prior to our current national guidelines, which we'll go through in a few minutes. She had no adjuvant therapy and is in just routine clinical follow-up. The second case is a 53-year-old lady who presented with a palpable mass. She indicated that it was very originally the size of a grape, but over many years, it had slowly increased in size, and because of some social situation, had not presented for imaging for a number of years. She had the mammogram shown here on the right, and a core needle biopsy which revealed a spindle cell neoplasm, which showed some mild cytologic atypia, some stromal overgrowth, and while there was concern for Phyllodes tumor, it was very uncertain. She elected for mastectomy for both an initial attempt at margins in case this did turn out to be a primary breast sarcoma. On final pathology, she was found to have a 9-centimeter borderline Phyllodes tumor with moderate cellularity and atypia, certainly stromal overgrowth, intermediate level of mitoses, and some focal areas of infiltrative permeative margins. So she had no additional surgical intervention. She had widely negative surgical margins, no adjuvant therapy, and she too is in clinical follow-up. The third case, this is the final case here, is a 45-year-old lady who had a roughly 3-centimeter palpable mass, but a very dense breast. As you can see, not quite so clear on her mammogram. She had reported some rapid interval growth at 3 months. She had a core needle biopsy, which revealed a fibroepithelial lesion, which had some stromal atypia, which gave some clinical concern for a Phyllodes tumor. She underwent an excisional biopsy, and on final pathology was classified as a malignant Phyllodes tumor based predominantly on some liposarcomatous components. Although well-defined liposarcoma is not enough for the malignant designation, this one was designated as such. She did undergo margin re-excision for a wide margin and needed no adjuvant therapy. So, surgical decision-making and adjuvant therapy is predominantly to prevent local recurrences, and this is a review from 2017 looking at local recurrence rates, and overall, approximately 15% of Phyllodes tumors will recur. This is a meta-analysis that was published a few years ago, revealing local recurrence rates by subtype. So overall, they found a 12% local recurrence rate with increasing local recurrence with increasing Phyllodes grades. So benign Phyllodes had an 8% local recurrence in this meta-analysis, borderline at 13%, and malignant at 18%. This meta-analysis looked at various features and their impact on local recurrence, and they found no difference in local recurrence based on either age of the patient or tumor size. There was also no difference in local recurrence based on surgery type, so both are deemed to be acceptable. They did find a very clear significant increase in local recurrence with a positive margin. However, on subgroup analysis by tumor grade, this positive margin did not remain significant for benigns and borderline Phyllodes. So their conclusion was that we may need to have differing margin guidelines based on Phyllodes tumor subtype. And at the time of this publication here in the United States, there was no difference in recommendations. The current recommendation was for a 1-centimeter margin attempt for all Phyllodes tumors. So we'll come back to more discussion about the margins and how we got here in a minute. In the United States currently, we have something called the National Comprehensive Cancer Network, or NCCN Guidelines, which publishes practice guidelines for various cancers, and they have a very small guideline here for management of Phyllodes tumors. Here it indicates with a clinical suspicion of a Phyllodes tumor, either an excisional biopsy or a core needle biopsy may be performed. Excisional biopsy being a complete removal of the tissue without obtaining a margin, again what we call enucleation, And there's a note that a core needle biopsy is more sensitive than an FNA, but neither reliably distinguishes fibroadenoma from phyllodes. Here at Duke University, we do not do any FNAs of solid tumors in the breast. Every woman would get a core needle biopsy. In terms of management, a benign phyllodes tumor may be managed with an excisional biopsy alone and does not require a negative margin by these guidelines. In just a moment, we'll review the data where that comes from and the recommendations. But you can see here, if you start with an excisional biopsy at the top and have a benign phyllodes tumor on final surgical excision, no additional treatment, no additional margin is needed, and you can go to clinical follow-up. If you start with a core needle biopsy and it's indeterminate or the suspicion is for a low-grade benign phyllodes, an excisional biopsy is deemed to be adequate. However, for borderline and malignant disease, they should undergo a planned wide excision with an attempt to obtain a surgical margin still of approximately 1 centimeter. And notably, they state that while a negative surgical margin is associated with higher local recurrence, it's not an absolute indication for mastectomy when you have a narrow margin. And I really agree with this. If we have a close but negative margin for a higher grade phyllodes tumor, borderline or malignant, I will not recommend a completion mastectomy. For all phyllodes tumors, we currently recommend clinical follow-up for 3 years, and this is because the median time to recurrence is roughly 20 to 24 months. We recommend the addition of a focal breast ultrasound to that lumpectomy cavity for 3 years every 6 months, as most of these will recur as a mass, which will be easily detected by ultrasound. Women who are over screening age for the United States, that's over the age of 40, they will get their annual mammogram on the 1-year mark. This is the largest series from the United States, and this was an 11-site multi-center data collaborative. And what's notable about this series is that of the women that had a final diagnosis of phyllodes tumors, which is this whole cohort of 550 women, 42% had a positive margin on their initial operation. And that's likely because most people go to the operating room just for an excisional biopsy without an attempt at a margin. Prior to the NCCN guideline change, the indication then was to go back for a wider margin to get that 1 centimeter margin. Interestingly, though, in this study, 1/3 of these patients did not go back for a second operation, which left a positive margin in place. Of note, on the left-hand side, you can see that 16% of women who had an initial negative margin also went back to the operating room, likely for a wider negative margin. So in this whole cohort, 40% of patients underwent at least 2 operations. Because of the low local recurrence rate in this series, as well as a number of other studies that led to our guideline changes, we no longer recommend a 1 centimeter margin for benign phyllodes. Local recurrence in this study was associated with tumor size, the malignant subtype, stromal overgrowth, and stromal atypia. Notably, it was not associated with a wider negative margin or even a positive margin. And the only real limitation to this study is that the low event rate or the low local recurrence prevented us from being able to do a multivariate analysis. Management of the margin continues to be a great debate, and many studies and many series look specifically at this topic. On the left-hand column are a number of studies that have identified a positive margin is impactful in local recurrence. And at the top, there's a whole series of very large studies that have been published in the last decade or so. The 2 that I highlight at the bottom are studies that indicate that a positive margin does matter, but a really narrow tumor-free margin alone might be adequate. And Zhang looked at a super narrow margin all the way down to differentiating between 1 millimeter and 0.1 millimeter, whereas the study at the bottom looked specifically at 1 millimeter versus 10 millimeters. The studies on the right are studies that identified that a positive margin are actually okay in some sense. The top two, Yam and Kim, both indicated that a negative margin was not necessary based on their analyses. Both Mu and Liu, which was the meta-analysis, both identified that specifically in the setting of a benign Phyllodes tumor, a positive margin was not impactful in local recurrence. Interestingly, the Memorial Sloan Kettering series that was published by Dr. Barrio a number of years ago noted initially that the positive margin did indeed matter, but when it was put into a multivariate analysis, that positive margin lost its significance. And so that was similar to the meta-analysis that was published by Liu. And I think these studies and the growing body of literature that margin may not be as impactful really led to our national guideline change for benign only. This is a quick slide looking at metastatic potential. The literature reveals almost non-existent data in benign phyllodes, and some authors believe that these are really misclassified other Phyllodes tumors. The rate for borderline is just 2%, and that for malignant is about 17. The vast majority of metastases, of course, go to the lungs, followed by disease in brain and bones. There is some literature supporting a potential genetic susceptibility, including a few reports of mothers and daughters both being affected, as well as sisters with Phyllodes. There are multiple reports of some germline mutations, including a strong association with the TP53 mutation and, of course, Li-Fraumeni syndrome. Our U.S. multi-center study of those 550 patients also looked at genetic evaluation, counseling, and testing, and approximately 10% of those women who were tested had a genetic mutation identified. And we currently recommend a careful assessment of family history and a very low threshold to refer to our genetic counselors for a discussion about testing. Currently, here in the United States, we have a multi-center study open, which is offering genetic testing to women with Phyllodes tumors of any subtype with any family history, and hopefully we'll have some more granular data about what mutations exist, their incidence, and what types. Hopefully that will result in the spring. This is just a real quick snapshot of what work is being done in the genomic space of these tumors. There are a number of gene mutations that have been identified in Phyllodes tumors and some clustering of these potentially actionable mutations in the borderline and malignant subtypes. There really is a lot of work being done to identify some therapeutic targets, as there's really no known systemic therapy right now that is impactful. The diagnosis and prognosis of metastatic disease is really quite dismal, unfortunately. Just a brief couple slides about radiation therapy. There are a number of studies in the literature that have looked at the impact of radiation on local recurrence for Phyllodes tumors, and this published paper was a systematic review and a meta-analysis, and you can see the studies included there. What they concluded is adjuvant radiation has in many studies impacted local recurrence, but there's really no effect on disease-free survival and overall survival. This series recommended that a prospective multi-center randomized trial be undertaken to really determine clinical benefit. What's notable is that local recurrence rate for Phyllodes tumors is quite high, especially as we compare those to adenocarcinoma of the breast fully treated. But what is also pertinent is that, remember, these women are 1 to 2 decades younger than the average patient with an adenocarcinoma of the breast, sometimes as young as 20s and 30s. This is a snapshot of the Nccn Guidelines, our national guidelines here, and their conclusion is that there's no prospective randomized data to support the use of radiation treatment for Phyllodes tumors. However, there's a note that says in the setting where additional recurrence would create significant morbidity, like a chest wall recurrence following a mastectomy, radiation may be considered. At our institution, we very rarely are offering radiation therapy to women with Phyllodes tumors, really reserved for locally recurrent, malignant tumors only, and potentially in the post-mastectomy setting where the margin is extremely narrow or positive. There's really no systemic therapy that's given to women with Phyllodes tumors. There's one study that continues to be cited out of Mexico a number of years back. This was a single institution and an observational trial, and all patients got 4 cycles of adjuvant chemotherapy versus observation for operable malignant Phyllodes. And what they found was really very poor prognosis overall, and the adjuvant chemotherapy was not impactful in overall survival. So I think in the interest of time, I'll just pass by this summary slide, but I thank you very much for your attention, and I would be very happy to answer any questions.
Well, thank you very much, Laura, for this beautiful overview and your own insights in the matter. We have some questions from the audience. Dominique asks what your recommendation would be on the frequency of thoracic imaging for follow-up of borderline and malignant Phyllodes tumors.
Yeah, great. First, I want to say thank you for the organizing committee for inviting me to come and talk. It's been really great to connect with some of your faculty, so thank you. So the question is regarding, it sounds like cross-sectional imaging, so I presume CT of the chest. And
yes.
We would not usually offer that for borderline disease, and that's because the event rate of distant metastatic disease is so low. That's about 2% if you look at pooled data. So we don't do it for borderline at all. For malignant, we would do a baseline as soon as we have a malignant diagnosis. So that might be immediately post-op. And then classically, we would get it at 6 months, 12 months, and once per year, just for a few years. And we usually will share these patients with one of our sarcoma experts. So each institution is a little different, whether this lives in the breast space or the sarcoma space. Here at Duke, it usually lives with our sarcoma team. So we usually combine with them to make decisions.
Okay, very clear. And regarding PET-CT scan, do you routinely perform those, or would it be the same?
Yeah, we don't usually do PET-CT. The vast majority of these will be metastatic to the chest, so to lungs, and we would not do whole body or PET-CT.
Okay, clearly. Well, there's a question actually for the technical support, whether it's possible to put back the summary slide so people can still make a snapshot of it. They're very curious. Let's see if there are some other questions. Yeah. Someone still wants to know whether there's a role for sentinel node biopsy in malignant Phyllodes.
Yeah, that's a topic that comes up frequently. And in the setting where you're performing breast conservation, so anything short of a mastectomy, there's no role. The positive nodal rate, if you look at big series, is very low, 1% or so in modern data. If you look back, sometimes that's quoted a bit higher, and it's often questioned whether there was a misdiagnosis of a synchronous adenocarcinoma of the breast or the pathology was not accurate. In the situation where you're doing a mastectomy and the diagnosis is not clear, so perhaps you have something that says spindle cell neoplasm, and that could be malignant Phyllodes, it could be primary breast sarcoma, or it could be a metaplastic carcinoma. In that situation, we will still offer a sentinel node biopsy. So almost exclusively for mastectomy alone, and usually only when the diagnosis is not certain.
Okay, thank you very much. And then for now, one last question. Well, it's actually regarding the margins, because you showed us quite a body of evidence to, well, actually not really care about those margins. And you only managed to change them for the benign Phyllodes. But what's your personal opinion on the margins in intermediate or malignant borderline or malignant Phyllodes tumors?
Yeah, I think sometimes, so for the benign, I have adopted our guidelines. I think the local recurrence rate is pretty low. You know, in the meta-analysis is 8%. I think in some of the other series is closer to 5%. So I will not go back for a positive margin in benign. I would say at this point, we're still going back if it's borderline or malignant, especially if there's some more high-risk features. So very high number of mitoses, permeative border histologically. So I would say we're going back, but not frequently to go back to complete the mastectomy.
And you would go back to perform a radical resection, but would you also go back if you have a close margin, let's say 2 millimeters?
Yeah, one recent publication that I need to add to my talk is there's a series of malignant phyllodes alone, and they looked at a more narrow margin. And in that single institutional series, there is some data that's saying a negative but narrow margin is also acceptable. And I think that margin in that paper, and I can send it out to you, is 3 millimeters. So if it's not super close, but just narrow, I would not go back.
Okay. And then, well, one additional last question, but it's from Frederick, so I have to ask it. Would you consider radiotherapy in case of a positive margin in borderline, rather than a re-excision when, for example, the re-excision would cause cosmetic problems?
Yeah, that's where it becomes to get tricky. The radiation is difficult in this patient population because we are now talking about women in their 20s and 30s and into their 40s, but these are not the classic adenocarcinoma of the breast where they're 60, 70 years old. So the impact of radiation is much greater. I think we would favor going back and really trying to get a better margin and avoid the radiation. And we give very little radiation here for non-metastatic phyllodes, non-malignant phyllodes. Thanks.
Okay, thank you very much once more. For the audience, it won't be possible to put back the last slide because we're looking at a film, but we will make them available later on. So still have the opportunity to get those. And then I will ask Frederick to take back the lead and, well, actually tell us something herself.